Hello, my name is Andrei Filippov, and my topic is immunotherapy in renal cell carcinoma. Immunotherapy with checkpoint inhibitors is now considered a standard of care for the frontline treatment of advanced renal cell carcinoma. Despite better outcomes with these agents, there is still room for improvement. The tyrosine kinase inhibitor sustatinib has been the standard of care in renal cell carcinoma for many years.
I think the most interesting data and the one that people are very excited about is the Emotion 151 that we just heard from Dr. Bob Moser. And this is a phase 3 randomized trial that looks at bevacizumab with atezolizumab versus sunitinib in a phase 3 setting for advanced metastatic clear cell kidney cancer. So let me just give you a little background on how we treat kidney cancers or advanced kidney cancers. So certainly there has been a lot of landscape changes. In the past, if we go back even a decade ago, we really did not have a lot of systemic therapies to offer. But now we have VEGF inhibitors, so these are what we call the TKIs. And certainly we have the immunotherapy drugs, but mostly for second line right now. So with the advent of these trial, the landscape of treatment is really changing. So in this phase 3 trial, though, what they saw was a phenomenal and very compelling improvement in the progression-free survival. The overall survival is yet immature, but we are seeing that there is two co-primary endpoints. One is progression-free survival in patients who are PD-L1 positive, and in this population, there was about 40% of them.
Applications in medicine. The robust activity of first-line immunotherapy in patients with renal cell carcinoma has raised the bar for future therapies. To advance the field further, we now need to improve upon response quality with more durable and complete responses. Combination regimens will build on the established efficacy of anti-pluripotent cell death protein 1 and anti-pluripotent cell death ligands 1 antibodies. Current standard immunotherapy for renal cell carcinoma includes nivolumab plus ipilimumab, aximumab plus pembrolizumab, adalimumab plus pembrolizumab, a high-dose interleukin dose.
I think when we look at the treatment for advanced renal cell carcinoma, it certainly has changed significantly. In past several years, renal cell carcinoma doesn't respond to traditional cytotoxic chemotherapy, and we had the advent of the first target therapies with the VEGF TKIs, over now, I guess, close to 15 years ago, that really showed an improvement in progression-free survival. And then for a while, that was the mainstay. And then, back in 2017, we saw the first data showing that immunotherapy has a role in the frontline treatment with the presentation of that for Nivo and Ipi showing improvement in overall survival in immune poor risk versus sunitinib. And then since then, we've had other VEGF IO combinations with both axitinib pembrolizumab and axitinib adalimumab approved by regulatory agencies, given in the case of axi-pembro improvement in overall survival and progression-free survival versus sunitinib in all patients in the risk group, and with axi-avelumab improvement in progression-free survival. And so, there's a wide variety of options to offer our patients now. With I think TKI monotherapy being used less and less, given this data, and both Nivo, Ipi, Axi, Pembro really becoming a new standards of care, given the overall survival benefit in patients with renal cell carcinoma.
Pros and cons. Pros: promising treatment will cure the disease, extends the life of patients, increase quality of life. Cons: expensive, difficult to acquire, not enough clinical trials.
So the things are clearly evolving for several years now, but especially since last ESMO, where we had the results of nivolumab versus everolimus randomized phase 3 study, which demonstrated that in patients who fail 1 or 2 VEGF-targeted therapy, there is a role for IO, immuno-oncology, and namely nivolumab. It is important because this is changing one of our standard of care, and since last year, this has been implemented in all the guidelines. What is important at this ESMO is that we're starting to have more information on which will be the next step in terms of combining those agents, for instance.
The issue applied in Ecuador. In Ecuador, renal cancer response frequently in men by 2.54% and in women by 0.9%. The most common carcinoma in the different subtypes of cancer is renal cell. Among the most important factors acquired risk of overweight addition to hereditary predisposition. Since this is a solid tumor, a specific treatment, complete repression nephrectomy, is today the only curative treatment of kidney cancer.
I will present a study called RADVAX, so radiation vaccination, if you will. It's a small study that asks the question, do we see something about this mysterious romantic abscopal effect in kidney cancer? So the question is, if we apply definitive radiation, high dose stereotactic radiation to a tumor site, can we potentially increase the response rate to potent immunotherapy? At the time when we designed the study, we took the most potent immunotherapy that there was, nivolumab/ipilimumab, a PD-1 and CTLA-4 inhibitor, and then really applied 5 fractions of high dose, very precise radiation to 1 to 2 tumor sites. And the question is, do we potentially see an increased response rate as a signal that maybe that approach may improve the benefit from immunotherapy? It's a small study, was supported by BMS with free drug, and more importantly was supported by philanthropy from patients actually to be able to pull that study off. 25 patients, we did see an increase in response rate, so we do see a signal that this approach may actually increase and benefit the immune response in that context. It will be opposed to data from an Italian study that used a little bit less radiation in just PD-1 monotherapy, where they did not see an increase in response rate. So maybe this particular combination, maybe the presence of the CTLA-4 inhibitor, maybe the intensity of the radiation, maybe some of these factors are important to do it. It's a small study and has all the caveats of a small single institution study, and there needs to be some complementary data generated to confirm the findings. One of the ways we're moving this forward with is that we are going to do PD-L1 PET imaging of patients. It's a very novel way to light up all the tumors in the patients and then see how inflamed are those, and then potentially pick out the ones that are the coldest, less inflamed tumors, aim the radiation to those particular disease sites, and see if that in particular will boost the immune response to otherwise very difficult to treat kidney cancer tumors.
Conclusion. Current data suggests that nivolumab, ipilimumab, or pembrolizumab are options for frontline treatment of advanced renal cell carcinoma and intermediate and poor risk patients. For further low risk patients, single agent sunitinib is advised, and with longer follow-up, nivolumab, ipilimumab may prove to be an option for this risk group. Novel combination strategies are being explored to deepen and extend responses, achieved with immune checkpoint inhibitor-based therapy.
Checkpoint inhibition, that is actually a form of immunotherapy. So that whole class of therapy, what it essentially does is ramps up your own immune system and releases the brakes that the tumor created to slow down your immune system from fighting your own cancer. It lets go of the brakes so that you can fight the cancer yourself. And when it works, it is actually astounding. It's really quite remarkable. It doesn't work for everybody, but when it works, it's really quite remarkable. Well, interestingly, checkpoint inhibition, again, this immunotherapy approach, that has exploded on the scene for bladder cancer as well. And that is rapidly changing the paradigm for the management of advanced bladder cancer. And so there's active trials ongoing right now trying to figure out exactly what space that therapy should fit in. Should it just be in metastatic disease, or does it have a role in locally advanced disease or even earlier stages? So that is probably the single biggest advance in the last couple of years, and it's just taking bladder cancer by storm.
Now the other topic is Ribavirin for chronic hepatitis E virus infection in transplant recipients. Definition: Hepatitis E virus genotype 3 causes self-limiting infection in non-compromised patients. However, it can lead to chronic hepatitis and cirrhosis in patients who have received solid organ transplant, patients with human immunodeficiency virus infection, and patients with hematologic cancers who are receiving immunotherapy.
Hepatitis E is RNA virus. Spread by the fecal-oral route. Incubation period 3 to 8 weeks. Common in Central and Southeast Asia, North and West Africa, and in Mexico. Causes a similar disease to hepatitis A, but carries a significant mortality, about 20% during pregnancy. In general, hepatitis E is a self-limiting viral infection followed by recovery. Prolonged viremia or fecal shedding are unusual. In acute infection, IgM antibodies to hepatitis E virus are positive. Does not usually cause chronic disease. A vaccine is currently in development, but is not yet in widespread use. Thank you for watching.
Applications in medicine. After more than a year of scrutiny and inspection by China's State Food and Drug Administration, a hepatitis C vaccine developed by Chinese scientists, HEV infection is usually self-limiting in saving patients with a suppressed immune system, where it can evolve to chronic hepatitis and cirrhosis.
Hepatitis E virus, referred to as HEV, is a common cause of sporadic and epidemic acute liver disease in developing countries. In the United States, sporadic cases of both imported and locally acquired HEV infections are mostly seen among adults. Incubation ranges from 15 to 60 days following exposure, with an average of 40 days. Liver enzyme elevation, as shown in blue and labeled ALT for alanine aminotransferase, usually occurs 4 to 5 weeks after exposure to HEV and persists for 3 to 13 weeks. Symptoms noted by the purple bar occur when liver enzymes are elevated. Virus excretion in stool, illustrated by the orange bar, is variable, but usually lasts from about 1 week before symptoms appear until about 1 week after they have surfaced. However, this time frame can be longer in some people. Viremia in acute self-limited infections, shown by the green bar, can be detected about 3 weeks following exposure or a week or so prior to onset of symptoms and lasts for about 2 weeks. Antibodies to HEV, both IgM anti-HEV, depicted by the pink hatched line, and IgG anti-HEV, illustrated by the black hatched line, are usually positive about 3 to 4 weeks after exposure. IgG anti-HEV persists, but IgM anti-HEV declines rapidly during early convalescence and is usually negative by 13 weeks. HEV serologic testing in persons with acute hepatitis for which other causes have been ruled out may be performed, especially in someone who has recently traveled to an area where HEV infection is more common. Chronic HEV infection is rare, but has been increasingly recognized in immune-compromised patients. Immunoassays to detect anti-HEV are commercially available, but are not FDA approved. Nucleic acid tests for the detection of HEV RNA are performed in research labs, but are not commercially available.
Pros and cons. Pros. All the patients have HEV viremia when Ribavirin was initiated, aspartate aminotransferase level at the initiation of Ribavirin. Cons. Hemoglobin level at the initiation of Ribavirin, dose reduction of interruption of Ribavirin.
Our lab studies hepatitis B and E viruses, which cause about 300 million infections worldwide and kill almost 1 million people annually. Neither one has a cure. We have developed new screening systems to identify new drugs to cure these viruses. Both hepatitis B and E viruses affect the liver, but they are very different viruses. Hepatitis B virus is transmitted through the blood and other bodily fluids. It enters liver cells where it hides in the nucleus. We try to find drugs that can kill this virus without causing harm to the patient. Hepatitis E virus infects people through contaminated pork meat and water. It stays within the cell body. We try to find molecules that can stop the virus from making copies of its genome. Our screening systems are faster and safer than existing platforms. Our systems are high throughput, meaning that we can screen millions of compounds within a short period of time. We modified both viruses so they are safe and robust for screening. The screening system closely mimics the situation in patients with chronic hepatitis infections. With these screens, we hope to provide cures for viruses that cause serious global health problems.
Issue planning Ecuador. Owing to the retrospective nature of the study, the control case series have several limitations. The number of patients studied was small, the actual level of immunosuppression that can play a role in HEV clearance was not assessed. Care was clinical driven, so the doses and duration of Ribavirin and the monitoring strategies different among the patients study sites, and Ribavirin levels were not measured. Conclusion. Ribavirin as monotherapy may be effective in treating chronic HCV infection. A 3-month course seems to be an appropriate duration for this therapy. Through a longer therapy can be given to heavily immunosuppressed patients and those who still have viremia 1 month after the initiation of therapy.